Today, I feel almost speechless. Why? Because we have the most amazing guest. Yes, I love all my guests. They are all wonderful and they teach us a lot. But this guest is extraordinary. She is really a philanthropist because she does so much for so many people. She's the incoming president for the American Society for Reproductive Medicine. She's a physician. She's a lecturer. She's a researcher. She does so much to advance reproductive rights and to help us all live in a safer and better society. It's really incredible. You will learn all about the new advances in medicine that are coming your way, but also about how to protect our rights and how to understand the things that we can do to help everyone. So tune in. Welcome to Building Your Family. This is a podcast about fertility treatment, donor conception, surrogacy, and all the ways the modern family is built. I'm your host. My name is Lisa Schumann. I'm a researcher, an author, a therapist, and I am so thrilled today to introduce you to somebody so special. Dr. Paula Amato is a physician. She's a scientist. She's a researcher. She's so many things, but how I look at her is as a philanthropist because she does so many things, including being on this podcast, where she just gives her heart and soul and time to all of us. And she is the president of the American Society for Reproductive Medicine. So needless to say, besides her regular job, she is super busy. And we are so grateful to have her here and tell us a little bit about things that are coming up in the future, things that we have to look out for, things to be hopeful for and excited about. So thanks so much, Dr. Amato. Really appreciate you being here today.
Thank you so much, Lisa, for inviting me. I'm thrilled to be here.
That's great. So tell me a little bit about what you're working on and maybe some things that people can start to think about. Maybe we can start to think about things in the more immediate future that people can be doing to improve their chances of success and how science has been evolving.
Sure. A little more introduction, as you said, I'm primarily a clinician, a reproductive endocrinologist. So most of the patients I see are infertility patients, and a lot of those undergoing IVF. But I also teach, and I also have my own research program, and I can talk a little bit about that. And as you mentioned, this year I have the honor of being president of the American Society for Reproductive Medicine.
Wonderful.
And the ASRM, as you know, plays a big role in educating both providers and patients. We do a lot of advocacy, we support research, and we provide guidelines as well, ethical and practice guidelines. As far as things on the horizon, this field has seen a lot of innovations in the last 40 plus years, of course, and there have kind of been peaks and valleys, I would say, of the innovation. ICSI was a big one. Pre-implantation genetic diagnosis was a big one. So there have been several. And now I think we're trying to kind of marginally improve what's already a pretty successful process, but not 100%, unfortunately, as people who have infertility and have undergone IVF know, the success rate is not 100%. So the things I would say I'm most excited about, we're learning a lot more about genetics, of course, and that's a major reason why embryos do not implant, or sometimes if they do implant, they go on to miscarry. So we have ways of genetically testing embryos now. There's a little bit of controversy around that. Not all the testing platforms are the same, and there's some concern that maybe we're discarding some normal embryos and that type of thing. But those technologies are improving at a very rapid rate. So I would expect to continue to see improvements in pre-implantation genetic testing of embryos.
That's amazing because, as I've said in this podcast, when I had IVF, we transferred 3 day 2 embryos. That was about a 20% chance, and we were happy for it. So life has really changed quite a bit.
It has changed. Like, I remember those days when we had to transfer a high number of embryos to get decent pregnancy rates, but now success rates have improved quite a bit, and we almost always transfer just one, very rarely more than one. So that has really helped decrease the multiple pregnancy rate. And as you and your listeners probably know, multiple pregnancies are associated with a higher risk of complications, both for the babies and for the moms.
Yes.
So we're happy about that. But in the future, we might even see non-invasive pre-implantation genetic testing. What I mean
Hmm.
by that, right now, to test an embryo, you have to do what's called a biopsy. You have to take a few cells from each embryo. It doesn't seem to harm the embryo, but theoretically it could. In the future, we might find ways to check the genetics of the embryos without having to biopsy the actual
Wow.
embryo. That might mean studying the fluid that it's surrounded in, or maybe there's some imaging technologies or what have you. But if we can improve that technology, we expect that will improve the survival rate and hopefully the pregnancy rates as well.
It's amazing.
In addition, the number of things that we can test for, of course, is increasing as well. Right now, we're primarily testing for chromosome numbers to make sure that there's a normal complement of
Hmm.
chromosomes. Of course, we can test for some single genes as well, like if a couple or one of the partners is a carrier for a genetic mutation that causes a serious disease, we can screen the embryos and make sure that they don't carry that particular condition. But there's also something on the horizon, well, it's actually already here, called PGTP, or pre-implantation genetic testing for polygenic diseases.
Hmm.
And this would basically, what it does is try and determine the future child's risk of developing more complex diseases like heart disease, diabetes, some psychiatric conditions.
Wow. It's incredible.
Right. My personal opinion is that the science is not quite there yet for that to be clinically useful, but I have no doubt it will improve, and it may be something that we see in the future.
For, the average listener who maybe goes to 23andMe, would we be looking at heritable diseases that maybe you could see on a 23andMe profile, or are there more intricate difficulties that would test for?
So right now we can look for most of the gene mutations that a company like 23andMe would screen for, and some of the other companies screen for these things as well. So if we know the gene that causes a particular disease, it's relatively easy to screen for those particular conditions. PGTP is a little more complex. It tries to screen for your risk of developing what we call complex diseases. So these are diseases that are not caused by a single gene, but many hundreds or maybe thousands of genes that each contribute a little bit to your risk.
Mm.
So heart disease, for example, there's no single gene that could tell you, you're going to develop heart disease, but there's a bunch of different genes that increase your risk. So that's kind of the idea. If you have 6 embryos, they'll be able to tell you this embryo is at higher risk for developing diabetes or heart disease.
Amazing.
Yeah, exactly. It's a little controversial, of course, because, people might be screening for non-medical conditions as well. For example, height or eye color or, you name any
Athleticism or
non-medical. Yeah.
Mhm.
Yeah. So that gets a little more controversial, but, I'm primarily interested in the ability for pre-implantation genetic testing to prevent disease, both in the child
Mhm.
and perhaps a future adult as well.
It's great.
Yeah. One of the other things that's kind of, you can't escape hearing about, of course, is artificial intelligence or
Mhm.
AI that's really permeated every aspect of our lives, including medicine. And we're starting to see AI applications in fertility treatment as well. It's still very sort of, there's a lot of potential there, but the research is still very early. So some of the things I'm most familiar with is AI trying to, for example, when you have an ultrasound and all, you have to measure each follicle, et cetera. So
Mhm.
AI can use whatever algorithms they use to measure all those follicles much more quickly. And they have all this data that they can, use to decide when to trigger to get the optimal egg maturity and optimal pregnancy rate. Those are the types of things that people are
Wow.
working. There's also other applications looking at embryos, imaging tens of thousands, hundreds of thousands of embryos to try and be able to select the embryo that has the highest chance of implanting and resulting in a healthy live birth. So I'm very excited to see where that goes as well.
And how would that work in the lab? Can you tell us a little bit about that? Because we've talked on this podcast before. Kathy Go talked a little bit about that, about her ideas about how this is going to really help embryologists in the future. Could you expand on that a little bit for the audience about how difficult it is currently for embryologists to make these decisions in the lab and how that might help?
Yeah, I think currently, a lot of those decisions are very subjective. So,
Hmm.
the embryologist is picking what looks to him or her to be the best sperm, and then which embryo looks best based on criteria, of course, but it is still very subjective, and there is some variability between laboratories and between individual embryologists as well. So this sort of automating every aspect of the embryology lab will make it not only more efficient, but will also standardize all
Mm.
these things. So
Wow.
hopefully, the hope is that it would improve outcomes. Again, it remains to be seen,
Hmm.
but that is the hope. If you can automize and standardize all these kind of what are right now very subjective manual procedures, then hopefully we would improve outcomes. People talk about a lab on a chip, for example, where like literally
Wow.
you get the egg and the sperm and put it in, input it in one side of some kind of contraption, and it comes out the other side as an embryo selecting the best embryo,
Oh my
like
gosh.
robotics, really. Yeah, yeah. There's already, I've saw a recent publication about a robot actually doing ICSI. That's where we inject one sperm into each egg. So you can imagine like every aspect of the embryology laboratory is facing, some automation, I think, in the future. We'll still need embryologists, so I don't want everybody to freak out. We still
No.
need humans,
Yes.
but a lot of these tasks will be automated, I think, in the future and have the
Wow.
benefit artificial intelligence. Yeah.
That's incredible.
Yeah. Other things that maybe are a little further off, but very exciting are things like in vitro gametogenesis. That's, the ability to make eggs and sperm from somebody's skin cell, for example. As you probably know, men can produce sperm throughout their lives until they die. But women have sort of narrow reproductive window. They're born with a finite number of eggs and eventually they run out of eggs. So, and as women are waiting longer to have children, what we're seeing more of is age related infertility, where women start trying to conceive later and eventually either they run out of eggs or the egg quality decreases, etc. So if this technology, in vitro gametogenesis, or IVG for short, comes to fruition, we'd be able to take a skin cell from a postmenopausal woman who's already run out of eggs and make an egg from that skin cell, and she could have a genetically related child. So whereas now you
Mm.
might have to resort to using an egg donor, for example, she could still have a genetically related child. Again, that technology is about 10 to 20 years off probably, but I'm fairly certain we will get there. It's already been done in mice, but of course,
Hmm.
mice aren't people. So there's a lot of research that needs to be done.
And we've already seen two male mice have a baby, right? So,
Right.
hmm.
Exactly.
Hmm.
Exactly. So that's the other application of this technology. You could have a same sex couple, two men or two women, have a genetically related child, genetically related to both partners. So whereas now one of them would have to use, or a couple would have to use either a sperm donor if it was a same sex female couple, or an egg donor if it was a same sex male couple, we could potentially make an egg from the skin cell of a male, and two men could have a genetically related child.
Wonderful.
Yeah, that would also decrease the need for donors as
Yes.
well.
Yes.
That same couple would, of course, still need a gestational carrier to carry the pregnancy, but it might reduce the need for donors.
Hmm.
Also, just people undergoing IVF, if you can make eggs from skin cells, you wouldn't need to do what we do now, which is, take about 2 weeks of hormonal medication, which causes all kinds of, side effects like bloating, etc. Then undergo a small surgical procedure to retrieve those eggs to be able to, fertilize them with sperm. If you could do that in a laboratory petri dish just from a skin biopsy, that would be a lot less risky for the particular patient or female undergoing those procedures like she has to now.
That's amazing.
Yeah. Yeah.
And which advances are you feeling most excited about right now, I would say? And then maybe next would be, which advances do you feel most concerned about?
I'm really excited about the in vitro gametogenesis, the IVG, but again, I think that's still a ways off. So I'm not sure we'll get there in the near future. There's also something called mitochondrial replacement therapy, which I've been involved in some of that research with my collaborators here at Oregon Health and Science University. But the idea here is that as women get older and their egg number and egg quality decreases, we think that might be related to mutations in the mitochondria in the eggs. And the mitochondria are these cell organelles, we call them, that are responsible for producing the energy in each of our cells. So it's kind of like the battery in the car. I've heard it explained like that before. So if the battery kind of dies, obviously the car can't be driven, right? So there's this concept of mitochondrial replacement therapy where you take a woman's egg, who's an older woman, let's say, having issues with fertility, you take the nuclear DNA out of that egg. So the nuclear DNA is what codes for all the traits that we think of, physical traits, everything. And then take that DNA and put it in a donor egg from a younger woman who's had its nucleus removed and just leaving behind the healthy, what we call cytoplasm. The cytoplasm is what contains the mitochondria. So you have this newly reconstituted egg that has the nuclear DNA from the patient. So any resulting child will be genetically related to the patient, but the supporting mitochondria of that egg comes from a donor. So it is egg donation, but it's not donating the nuclear DNA. It's just donating kind of the cytoplasm. So not the yolk, but
just the energy for the energy
exactly,
for the
egg.
white
part of the egg. But then you could fertilize that egg, and hopefully the pregnancy success rate would be higher because that egg would now be effectively younger because it has younger mitochondria. So there's actually been several babies born from this technology. Initially, it was developed to prevent what we call mitochondrial diseases. Some women actually carry disease-causing mutations in their mitochondria, and this would be a way to circumvent that so that they could have healthy children. But then somebody, had the idea, well, maybe it might help older women who are struggling with infertility as well. So there was one small trial published last year that seemed to show that it's safe to do. So I look forward to more research in that area.
That's super exciting.
Yeah. One of the barriers or obstacles, of course, is that even though this technology and many of these technologies are developed in the United States, currently we can't really do a lot of embryo research, or certainly not any clinical trials that involve human embryos in the United States for various reasons. So we can't move this technology really to the next step, which would be a clinical trial in the US, which means probably many of these trials will have to be done elsewhere.
And they are proceeding, right? In some other countries, we've seen people experiment with these procedures there.
Exactly.
And so far they've been fairly positive, right? Even though it's a little scary, it seems like, as far as we know anyway.
Exactly. I think it's not ideal because obviously the United States has a pretty robust human subjects protection system, for clinical trials. And ideally, we would love to do those trials here in the US where we have more oversight, but that can't happen right now. Nor can we get funding from the National Institutes of Health for most of these studies because, again, they involve human embryo research. So that's a bit unfortunate, but we'll have to look to other countries. Hopefully, they'll have safety precautions in place for the patients and any resulting future children.
Right. And hopefully by the time we see it, some of the kinks will be worked out and we'll have some better idea of if these things work or not.
Exactly.
My name is Lisa Schumann. I'm a therapist, a researcher, an author, and I am passionate about helping people find a better journey to parenthood. I created the Center for Family Building to help people understand how to make decisions, not just for the short term, but for a lifetime. We have group counseling, individual counseling, couples counseling, and lots of other services that can help people find the answers that they're looking for. Just take a look at our website so you can see a few of the thousands of people we helped build a better path to parenthood. The decisions you make are too important to leave up to chance. Arm yourself with the right information. Take a look at our website and sign up for a session with one of our therapists, join one of our groups, or access one of our programs, and you will quickly see why our strategies are so effective. Now back to our episode. Speaking of that, what about CRISPR? There's so much discussion about that, and where are we with that, and how is it involved in vitro fertilization?
I think by now probably everybody's heard of CRISPR and won the Nobel Prize actually a few years ago. Basically, it's kind of molecular scissors. It can cut the DNA and serves kind of like a cut and replace function, to use a Microsoft Word analogy, in your DNA. There are many uses, but in our field, people started to wonder, well, what if we can actually correct a gene mutation at the level of the embryo instead of having to wait for the child to be born and then, treating that child potentially with a gene therapy. And there have been some gene therapies developed in the last few years. Problem is they're very, very expensive. They can be up to $1 million or more per patient. Yeah. And they're not exactly 100% effective either, because that CRISPR needs to get into every cell of your body that carries that mutation. Whereas an embryo, of course, is a single cell. It's very easy to CRISPR one cell compared to many billions of cells. Not to mention that if the treatment's very expensive, then it's not going to get to the people who need it most. For example, one of the newer available treatments is for sickle cell, and most patients with sickle cell live in sub-Saharan Africa, and certainly not many people in sub-Saharan Africa that could afford $1 million gene therapy, and nor could their health system. So we and others had the idea, well, what if you could correct the mutation at the level of the embryo? So we already do this to some degree. It's not gene correction, but it's selection. So if you're a carrier for a genetic disease like cystic fibrosis, for example, you could undergo IVF, generate some embryos, then do genetic testing on the embryos, and then pick the ones that don't have the disease to transfer into the uterus. And depending on the condition and how it's inherited, a certain percentage of those embryos are going to be normal. And that's great if you're young and you produce a lot of eggs and you produce a lot of embryos. There's lots of eggs and embryos to choose from. But not so great if you're a little bit older and maybe you only make 3 or 4 eggs. And, some of those are going to be chromosomally abnormal. And so then you're selecting for, the one that's chromosomally normal, but doesn't carry the gene mutation that causes this. Your chances kind of decrease, and you're ending up having to do multiple cycles to get a normal embryo. So the idea here would be, well, what if we can correct the gene mutation in the embryo? So we and others have used CRISPR, injected it into the embryo to do this cut and replace function, to take out the mutation and put in some healthy DNA, culture that embryo in the petri dish. And then obviously we can't transfer the embryo yet because there's a lot of research that needs to be done to make sure it's safe, etc. But we have shown that you can actually do that. You can correct the mutation. Problem is that things like CRISPR make cuts in other part of your DNA where you might not want it to cut. So there's a lot of safety considerations. So that would all have to be worked out before it ever became available for clinical use. Other sort of issues with that are more ethical, like who's going to have access to this technology if it's developed. And it's fine if you're trying to use the technology to prevent diseases. But again, how about if people start using it to
Use
for
hair color.
non-medical reasons. Right, exactly.
Yeah.
Or,
Yeah.
we figure out whatever genes are responsible for height and athleticism and intelligence, and people are trying to, genetically edit their embryos to make them, smarter, more athletic, whatever it is. So that
Hmm.
kind of smells a little bit of eugenics, right? So
Yes.
people are
Yes.
very concerned about that sort of slippery slope. So that gray line, it's some things are clearly medical and some things are clearly non-medical, like eye color, for example, hair color. But there's
Right.
lots of gray in between, and I think people are concerned about that, and rightfully so. And I think we should be having those conversations as a society with ethicists and lawyers and philosophers, because science is moving ahead, whether we like it or not. We can't kind of put the brakes on the science, I don't think. And we can't wait till the science fully developed to start having those conversations. So they really
Right.
need to be happening together as we think about the research, keeping in mind how people might use this technology for good, but also, for not so good purposes. And in some
Right.
cases, maybe nefarious purposes like,
Yes.
war and that type of thing. So really important
Yes.
to think about those things.
And you're in a very unique position, Dr. Amato, because, many physicians who become president of ASRM are not always also working in research. And so if you could only have your research hat on, you could just keep going down that tunnel with your blinders on and that's it. But now you're also in this position where you have to be thinking about all of these things and really running a whole community and leading this whole organization, which fortunately is still self-governing, right? We're still lucky enough to not be in a situation where we would have to answer for every single, move of the pencil to the FDA or the, CDC or whomever. So that's great. And of course, we all want it to stay that way, but you're kind of in this tough position where you have to juggle these things probably every single day.
Yes, that's so true. And I agree with you that I think, the people in the field are probably the best people to be regulating these
Hmm.
technologies. And of course, there's oversight from other government entities and that type of thing, but really the people in the field. And we've done a pretty good job historically about
Yes.
regulating our own field. But you're right. Like I said, I'm honored and to have the privilege to serve as the president of the American Society for Reproductive Medicine this year. And one of the reasons that policy and advocacy appeals to me is because you can really impact so many people. Like when I see patients in my office, which I truly love, I love seeing patients in my
Hmm.
office, and you have a huge impact on that particular patient and growing their family, like what more impactful thing can there be than, having children? But at sort of the organization level, policy level, government level, you can pass a policy or prevent a bad law from taking effect, and it can impact tens of thousands, sometimes millions of people.
Yes.
So,
Yes.
one of the things that ASRM is very committed to, as you know, is increasing access to care. And,
Hmm.
we're fighting every day to try and increase insurance coverage for infertility services for patients who need it. Also protecting those rights in some states where
Yes.
various groups have tried to take those things away. So that's a super important part of my job that I'm thrilled to be working on it, just but very humbled by the nature that or the thought of that it could actually impact many, many more people.
Yeah, it's tremendous. It's really tremendous. But you're also sitting in a seat of having to wear both of those hats all the time. The ASRM is really also responsible for generating the research and helping the fellows and helping everyone who's starting in this community to grow and educate themselves. And so you're helping to advance education at the same time trying to steer us in the right direction ethically. And that's really a tough thing to do because as you said, there's really no way to know how some of these things are going to unravel in the future, right? I remember ICSI, everybody was so scared of it in the beginning, right? And fortunately, everything worked out beautifully, but there's always a lot of scary things to think about potentially, and that's a tough tough situation. I mean, it's beautiful to be able to be part of it, but at the same time, I think probably a little anxiety producing.
Yes, absolutely. I remember the early days of IVF, maybe you do as well, where the
Hmm.
headlines were very scary and very
Yes.
similar now to the headlines associated with things like gene editing of embryos or in vitro
Hmm.
gametogenesis, et cetera. But like you said, in some ways, I think we were lucky that everything turned out mostly fine.
Hmm.
But there's always a risk that it won't. But I also agree that ASRM plays this really important role in educating the next generation of
Hmm.
reproductive endocrinologists and urologists and therapists, genetic counselors, reproductive attorneys. It's really unique in that way that it's a very multidisciplinary organization, and it really,
Hmm.
as you know, as you talk about in your book, it takes a village, right, to build a
Yes.
family sometimes. And I think ASRM does a particularly good job of trying to educate both patients but also practitioners in this field as well.
Yes. And speaking of which, this year ASRM issued their new definition of infertility, right?
Yeah.
Which is really incredible.
Exactly. That's one of the ways we've been trying to increase access to infertility services and infertility treatments. So the new definition includes, in addition to heterosexual couples who might be having difficulty conceiving, also includes single people who are using assisted reproduction to try and build their families, as well as same sex couples who often
Mhm.
or almost always need medical assistance to build their family. So it's much more expansive. And we think that might be helpful in terms of trying to get insurance coverage to pay for some of these things.
Yeah, that's a beautiful thing. It's so nice, really so wonderful to see because for so many patients, as you know, it's so frustrating to be able to have to come into a clinic and say, well, why do I need to prove my infertility if I'm, for a woman, if I'm never having sex with a man, why do I need to spend umpteen dollars on multiple cycles and I know we're going to have trouble.
Exactly.
So,
Exactly.
yeah, that's really fantastic. And in terms of the advocacy piece, you just mentioned there's so much happening right now. And I would imagine that ASRM is, I know, very involved with Resolve in helping to try to do everything that they can to try to block some of these personhood laws, but also to try to advance some good education because there's so much ignorance out there, sadly. And I think many people struggle with that because they just don't have the facts, and don't understand the need for reproductive medicine. So, what are your feelings about that and ASRM's role, and where do you see because ASRM has to do so many things and can't do everything, of course. So how do you feel that we can all help as members of ASRM and members of this community?
Yeah, very good question. This year has been particularly challenging with the Dobbs decision and the court ruling in Alabama. So ASRM advocacy folks have been super active trying to address those particular issues. There's also a bunch of anti-trans legislation that we're involved in, all kinds of things. What we found to be most effective is something you touched on, like the providers partnering with the patients, like Resolve and other patient advocacy
Hmm.
organizations. That is really the most effective because the patient stories is really what moves legislators. I could go there as a
Mm.
provider and yes, I can educate, but it's really the patient stories that move patients. And you do that a little bit in your book, Building Your Family, as well, where you use patient stories to illustrate and
Hmm.
educate. And I think that's very compelling. I think you're right. And there's a lot of misinformation or ignorance because people don't learn this stuff necessarily in school unless you're like immersed in infertility treatment. You might
Yes.
not know the
Yes.
difference between an embryo or blastocyst or whatever, and these are the people writing the laws. So sometimes
Hmm.
there could be intentional effects but also inadvertent effects that really might affect the practice of IVF and your ability to use this technology to build your family. So ASRM, of course, is monitoring all this legislation and working with legislators, trying to educate them so that, laws aren't passed that will harm patients and not give them access. But almost always we partner with patients because that seems to be the most effective. Of course,
That's
politics
great.
is a big part of it. There's the anti-choice movement that is
Mm-hmm.
behind a lot of this legislation. And the separation of church and state is a constitutional right in this country, and it exists for a reason. And the reason is to protect religious liberty. So I am totally fine with these, people that might have religious or moral objections to some of the things we do. I think where the issue is, though, is where those same people are trying to impose those religious beliefs that are not shared necessarily by other people,
Mm-hmm.
and they're trying to impose them on somebody
Yes.
else. And that's not okay. I also feel badly for, the patients, to be honest, because,
Mm-hmm.
faith is plays a big role in people's lives, and especially patients undergoing infertility treatment, and they may be, Catholic or whatever Christian denomination, and to hear their leadership, which is often, older cis white men, I might add,
Mm-hmm. Yes.
making these declarations about how IVF is immoral and it shouldn't be allowed and it should be banned, etc. It's really harmful to those
Yes.
patients, and I feel
Yes.
bad for them, and I want to empower them to make their own decisions. Of course you're going to take your faith into consideration as we all develop our sort of moral compass, if you will.
Yes.
Patients should feel empowered to act according to their conscience, and work with their physicians to find the treatment that's most appropriate for them. I'm not saying everybody should do IVF if they don't want to do IVF, or just like not everybody should have an abortion if they don't want to have an abortion, but they shouldn't
Right.
limit other people's rights to make those decisions for themselves. And I think that's where, we draw the line.
That's so well said, Dr. Amato. So well said. I completely agree with you. And you're right, it's so sad for a lot of these people who feel pressure and feel that it's so difficult for them to access treatment. And then also the people on the other side who access treatment and are afraid to keep their embryos in their state now. And, there's a lot of fear and anxiety out there. And, I think that people don't realize that everyone in this community just wants to help people have the dream of having a family, which is everyone's right if they want to pursue it.
Totally agree. I feel like people don't understand how inefficient the reproductive process is, even naturally, right?
Yes.
Like most embryos, it's thought, in the body don't actually result in a live birth. So it's no different
Hmm.
in the petri dish. I feel like many politicians don't quite get that.
No, that's so true. And well, we also we don't learn that in school, right? We just learn about how not to get pregnant,
Right,
and this is right. These are the things you have to do to prevent pregnancy. There's
right,
really no education about infertility or your reproductive potential or
right.
aging on your gametes. I mean, there's nothing about that in school.
Exactly. Contraception obviously is also important, but the
Yes.
other side of the coin is also important. It would be, I think we'd be better off as a society if more people had just like a basic understanding about how reproduction works.
And I'm sure you see in your office every day people who come in and they're, cross-eyed because they don't remember their 10th grade biology and they have no idea what you're talking about when you're talking about follicles or your uterus or anything. People just don't know.
Every day. I can't tell you, at least once a week, somebody comes into my office who's like 40 plus and is like, what do you mean I'm not getting pregnant because of my age? I feel very healthy. I work
Hmm.
out. I eat well. I'm
Yes,
normal
right.
weight. And I go, I know you're very healthy. That's great. But your eggs are not.
Right. Right.
Or you run out, you have very few left. And even that is, it's a basic thing that women are born with a finite number of eggs and eventually you run out and your fertility declines way before you run out is not. I think we're doing better now about educating people about this, but it still surprises me that not everybody knows that or gets that or learned that at some point in their lives.
Right. I mean, we can kind of accept that our hair gets gray, but we can't accept that our eggs get old for some reason, right? Even if I exercise and I'm vegan, my hair's not going to stop getting gray.
Exactly. So,
It's so true. Yeah. So
yeah.
we need so much education, I think, everywhere. And you're only one person, and you're doing so much, Dr. Amato. I really appreciate your time, and I know you're short on time. I just wanted to ask you if there is anything that we're missing that we should be thinking about going forward.
Nothing that comes to mind right now, but this, one of the reasons I love working in this area is because there's always something new and interesting and exciting. I'm sure you find that as
I
well.
do.
So stay tuned. I'm sure there'll be something else. You can invite me again in the future. I'm sure there'll be more to talk about. But I agree with you. I want to congratulate you on your book and your podcast. I think you're playing a big
Thank you.
role as well in educating the public, all your listeners. Just these are things that not just people struggling with infertility, but everybody who's building a family, who has children, who may be building their own families in the future, really need to think about and know about. So thank you for doing that.
So much appreciate that, Dr. Amato. Really appreciate it. It means so much coming from you, and I'm so grateful to have you here. Where could people reach out to you? Can they just stay in touch with ASRM or contact your practice?
ASRM is a good resource. Resolve is a good resource. I practice in Portland, Oregon, so certainly if you're local here, reach out to our clinic. Pretty easy to find online. I'm on Twitter. I'm on LinkedIn. So
Oh,
yes, if
great.
people have comments or questions, I love to get email and stuff.
Okay, terrific. Well, thank you so much for coming. I really appreciate it. And thank you, everyone out there, for listening. These are such important conversations to keep having. I hope that you enjoyed it and got something out of this, because this is really important that we all stick together. We all can make change if we do that. So thanks so much for your time. And please subscribe, because that's how we keep going. And I'll see you next time.
Thanks so much, Lisa. It was my pleasure.
Hi, it's Lisa Schumann. I hope that you enjoyed that video, and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.